Duna.
Yay.
Hello there. Welcome to Medical Mondays with Dr. O, your interactive platform where we share medical information and all the relevant health news you need to know for a better life. Be reminded that this platform is not establishing care. Rather, we bring you the thoughts and the expertise of highly qualified professionals in the medical field to arm you with all the information you need to live a strong life, strong health, strong future. This evening, we'll be discussing obstructive sleep apnea in children. What are the signs to look out for? What is the way to go about it? With an expert in the field, Dr. Oluwole Ajagbe. Dr. Toyin Opesami is a family practitioner, HIV specialist, CEO, and medical director of Janasarek Medical Center. And she is committed to changing lives through healthcare. Dr. O, you're welcome.
Thank you so much, Honorable Gustav. And welcome, everybody, to another Medical Mondays with Dr. O. This forum tonight is very, very special and dear to my heart, because when we talk about obstructive sleep apnea, we think of adults. But in children, if you see the title, it says obstructive sleep apnea in children. And you know, all that our very able, knowledgeable Dr. Ajagbe is going to share with us tonight. I cannot wait. So I'm gonna hand over to Dr. Oluwole Ajagbe and have him complete his own introduction. Welcome, sir.
Good evening, everyone. Thank you, Dr. O. I'm very glad to be in your midst again tonight. Haven't been away for almost 8 weeks, having fun in Nigeria while raising awareness about obstructive sleep apnea. Because that's one area in Africa that it doesn't seem like anybody even cares about. Because when they talk about snoring or anything like that, everybody assumes that it's a hereditary stuff, and it is from family, from grandfather to father to son, and then passing on to next generation. But there is more to obstructive sleep apnea than meets the eye. Tonight, I'm not going to spend time just, introducing myself. Anyone who wants to know more about me can contact me personally. But let's quickly dive into this issue about sleep apnea in children. The pathology or the pathophysiology of sleep apnea is the same, whether it is in adults or in children. But the predisposing factors may vary from children to adults, and that is from the standpoint that many of the children that have underdeveloped jaws actually were children that didn't have a long-term breastfeeding when they were infants, and that affects the development of their tongue as well as the development of their jaws. And once the jaws are not well formed, the tongue has no room in the mouth, and the default is that the tongue will fall to the back. Now, if the tongue falls to the back while the child is awake, the child can still control it because the child can try to swallow, and the tongue will move forward and the airway can be opened. But the danger is when they are sleeping. When they are sleeping and the jaws are small, there is no space for the tongue will be pushed to the back. And that automatically blocks the airway and causes airway restriction. Sometimes if it's partial, the air can still pass through, but with a lot of vibration, and that is what we pick up as snoring. The other thing that we must remember about children is that they are in the development stage. Their jaws are not well formed, their nose are not well formed. And in most cases, when the nose is underdeveloped, as well as the, actually, when the jaws are underdeveloped, particularly the upper jaw, the nostrils will also be underdeveloped. And that often causes nasal blockage on a regular basis. Most of the time, the child will be thought to have allergies. They would be thought, they think that they have cold, but most of the time is because the nasal passage is partially blocked, and when the air passes through at high speed, it causes irritation. So most of the time, these children have what we call the upper airway restriction syndrome. That is, their nostrils are blocked, and automatically they default to open their mouth, and that is a coping mechanism in order for them to keep on being alive. Now, when we are talking about sleep apnea, the sleep apnea is like a vicious cycle. The first thing is there's upper respiratory restriction. That is, the nasal cavities are blocked, either completely or partially. In some children, one nostril is blocked and the other one is partially open. So they are struggling to breathe, even when they are awake. Now, this kind of children, or these children, will default to opening their mouth in order for them to get more air into their lungs. But that is a very inefficient way to breathe. So they are not going to get enough oxygen the way the body needs it. So now, when I said it's a vicious cycle from the standpoint that they cannot breathe through their nose properly, they open their mouth to breathe, and the air going into their mouth is not prepared the way the nostrils will prepare the air to go into the lungs. So these children are going to have problems with their tonsils and adenoids. They will swell because the air going in are not purified. The air going in are usually dry, and that will cause the irritation of the adenoids as well as the tonsils. And so they have even more pronounced air blockage once that happens. So during the day, they can't breathe well. During the night, they can't breathe well. These children are going to always appear as tired, with big ring of dark circle around their eyes. They look tired and they feel tired very easily. They cannot run around with their peers. If they try, they get weak. They get tired and stop without, while the others are still playing, they are too tired in one corner. These children usually do not have very good development of their brain because there's very low oxygen saturation in their brain during the day as well as in the night. But what we are focusing on tonight is that these children that have obstructive sleep apnea have other things that show up, particularly when the sleep apnea is not recognized, is not diagnosed, and is not managed or treated. So in the situation where the children are suffering from sleep apnea and they are not treated, the long-term consequences are very grave. One of the things that happens to them is that they will be bedwetters. Most of the time, for those of us who grew up in Africa, I don't know too much about bedwetting in the US, but in West Africa, particularly in Nigeria, when a child bedwets, is actually that child's fault. That's the way the parents will look at it. They treat the child with disdain. They shame the child. They abuse the child. They beat the child up. Sometimes some parents are so frustrated that they actually take the child to school to tell their peers that they bedwet, so that maybe the shame will cause them to stop. Because many of these parents are so ignorant. Actually, let me just say, all of the parents were ignorant of what the cause of bedwetting was. So these children, self-esteem were destroyed. And it's a vicious cycle. Remember, these children cannot sleep well at night because they stop breathing several times at night. The brain doesn't get enough oxygen. So during the day, they are sleepy, they're tired, they cannot concentrate. Now, I will share with you within a few minutes that there are research studies that actually point to the fact that children that have sleep apnea that are not diagnosed and are not treated have a high tendency for low IQ. And the result is very staggering. It was a study done, published in 2012 that actually followed some children, about 11,000 children for 6 years, and saw the effect of, sleep apnea on their neuropsychological development. But now let's quickly just look at this issue of bedwetting. The bedwetting is not the fault of a child. I don't know whose child has been suffering from bedwetting and nobody knows how to treat this patient. Even pediatricians, most pediatricians do not know how to manage the issue of uncontrolled bedwetting. Any child that is bedwetting and there's nothing that has been done and there's no bladder infection, there is no anything structural in the urinary system that is causing them to bedwet, they must be evaluated for obstructive sleep apnea. And once that is diagnosed and it is treated, bedwetting will automatically disappear. And that's the way it works, because it is a sympathetic nervous stimulation that is causing the bladder to empty inadvertently when the child stops breathing. The brain arouses them to a level of awakefulness, which is not being alert. They are awake, but they are not really awake. They think they are on the toilet, they want to pee because their body wants to get rid of sodium, because when the brain senses that the oxygen level is low, it senses it as like a situation that they have to react to in a very like a hostile environment. So one of the ways to get rid of that is to lower the blood pressure. And one of the ways to lower the blood pressure is to get rid of sodium, and it's through urination. And so this child or these children who are bedwetters will wet their bed even before they can get up to go and use the toilet. Now, we want to raise the awareness to the level that the parents should know that it is not the fault of the children. They are not doing anything wrong. So if parents have been punishing their children by not letting them drink water, in the evening, by not giving them dinner, or saying that if they ate dinner, they are going to pee in bed and things like that, they should not do this. They are destroying their children, because most children that do have obstructive sleep apnea, they have what we call failure to thrive. They do not grow properly, because most of the time they cannot sleep well at night. They do not breathe well during the day. They are weak. They cannot exercise. They are not eating well because the parents, some of them are punishing them. And all of these things is like a vicious cycle. That child is being destroyed inadvertently. So ignorance is no longer, something that we should, embrace. We should at least make attempt to learn more. And I thank you all for being around tonight to want to at least hear something about this issue. So for bedwetting, it is treatable. And first of all, we must diagnose or recognize the underlying cause. Another thing that is being found linked to bedwetting and to obstructive sleep apnea in children is attention deficit disorder. Most of the time, we don't realize that because we see it. The doctors diagnose this as psychological problem or psychological problem that needs to be medicated. Well, if a child is distracted during the day and is hyperactive and is causing trouble, most of the time is because they're trying to stay awake. Many of them that cannot do that, they will fall asleep during the day because they have excessive daytime sleepiness because they have not been able to sleep well at night. Any individual that has frequent stoppage and breathing during the night, as we call it, sleep apnea, if they have anything more than 5 events at night, will have problem during the day. They will have problems staying awake. They will have problem concentrating. They will have problems, even performing simple tasks that other children will normally perform. So let's take a look quickly at this study by Dr. Bonak that was published in 2012. This study followed 11,000 children for 6 years. And the goal of the study was to examine the statistical effect of sleep disordered breathing symptoms trajectories from 6 months to 7 years on subsequent behaviors. And what are the results? What are the results of the study? The first finding is that there is a strong and persistent association between sleep disordered breathing and diminished IQ. The second result that was found in this study was that sleep disordered breathing increased the risk of ADD/ADHD by 50%. That is a very high risk right there. The last but not the least result is that sleep disordered breathing kids were 40 to 100% more likely to have neurobehavioral issues. Now, what are the implications of the findings? Look at the medications. If we look at the medications that have been prescribed for ADHD in children, it is said by American Psychiatric Association that 5% of children in America have been diagnosed as having ADHD. And they discovered also that 11% of children from ages 4 to 17 have been diagnosed with ADHD. That was published by CDC in 2013. In 1990, 600,000 children were on medication for ADHD, but it is exponentially exploding. By the time it was 2013, 3.5 million children are medicated for ADHD in the United States. Now, the prescription, I'm talking about the implication of not recognizing the diagnosis, is financial. It's exponentially. If you look at how much money that has been spent on prescription drug for these children, it is in excess of $9 billion annual sales. So this has a financial implication as well as quality of life of the children have been diminished over time. And if it is not treated with urgency, many of these children will not grow up to be functional adults to the point where they might just, many of them will die prematurely. But we're not going to go into other aspects of it other than the fact that these are issues that can be managed. The issue of mouth breathing, the issue of bedwetting, and the issue of ADHD. Any child that has been diagnosed with ADHD should be evaluated for sleep apnea. Even if it comes out to be negative, it's best to do that than not to do it. Because if this ADHD and behavioral problem was as a result of not having enough rest at night, and you are using medication, that child will not improve. There will be no reversal. So let's bear that in mind. And at this point, I'll just stop. And I know there'll be questions, and then we might delve into some other aspects from this point.
Thank you so much, Dr. Ajagbe. Whew. Who would think that sleep has anything to do with bedwetting or ADHD. You know, last week we talked about lifestyle changes and found out that there are three basic things that are actually very, very important to changing one's lifestyle and maintaining excellent health: good diet, exercise, and sleep. And here you come today, Dr. Ajagbe, to come enlighten us, you know, that sleep is not only important, but especially in children, because, you know, the foundation has to be laid right. I think that's what I just got. So I'm just wondering, what part does weight have to do with this? Does weight have anything to do with this in children?
Absolutely. It's a vicious cycle that keeps coming back. You know, the first thing that you must realize is that a child that doesn't sleep well at night will crave the unhealthy food to stay awake. Things like chips, things like cookies, crackers, and stuff like that. Those are the processed food and highly refined carbohydrates type of sources of, you know, snacks that they give to them to stay awake. Those children are going to be the same kind of children that will eat, fast food because, you know, the parents wants to just get them something real quick. They are always in a rush because they're not up and about early in the morning. Yes, there's actually a body of studies or data that supports sleep apnea being foundational to obesity. And the food choices that people make, whether adults or children who have sleep apnea, are not healthy, and that will contribute to their weight gain. And we know that any human being, any adult or children that have a neck size from 15 and above, 15 inches and above, have the potential to have obstructive sleep apnea. Because anyone who has a fullness in the neck with excess fat being developed there has nowhere to go but to press or compress the airway in the back. So one of the things that we must always bear in mind is we must check for the weight, as you know, normally being checked with BMI, as well as the neck circumference in children, not just adults. Children's neck sizes are important. If any child's neck is approaching 15, 16, you know that is not, normal for the age of the children. But if the body is already big and the neck is big, you cannot just reduce the size of the neck by itself. It has to be a lifestyle change. And most of the lifestyle change will have to do with food choices, changing the diet and exercising, and any other thing that could actually help them to reduce their weight.
Thank you so much. There's a question in the forum that says, can this be treated?
Can what be treated? The sleep apnea?
Sleep apnea. Can it be
treated?
Yes.
Oh, yes. Sleep apnea can be treated. Actually, treating sleep apnea is a multidisciplinary approach that is now being recognized. It used to be in the past that every specialty that seems to have something to do with the airway believes that they are the expert to treat sleep apnea, but it is now being discovered that there is no one single discipline or specialty that can handle obstructive sleep apnea. It's a multidisciplinary approach that is available nowadays. This is the current thinking, and anyone who wants to treat obstructive sleep apnea by themselves will probably be able to accomplish very little unless other modalities have failed and they just want to try another particular modality. Yes, it can be treated. There are at least 37 treatment modalities for obstructive sleep apnea. And the one that seems to be dealing foundationally with whatever it is, if it is anatomical basis for the obstructive sleep apnea, is the biomimetics. All the other things do not address the underlying causes. The only device that has been approved by FDA for the management of obstructive sleep apnea in both children and adults is the biomimetics. We call it mRNA. mRNA is a device that is custom made for the individual, and it is used in the evening and in the night. It is not used during the day. The goal of it is to reposition the jaw at night, at the same time use epigenetics to stimulate the growth of the jaw bones in order to create enough space for the tongue so that the mouth can actually house the tongue without the tongue falling back to the throat during the time of sleep.
Thank you so much, Dr. Ajagbe. There's a question from Dr. Bill says, how does a subclinical allergenic state in children impact obstructive issues?
Suballergenic, in what sense? That is undiagnosed allergenic state? I want to understand what that question is addressing. Dr. Bill, can you clarify?
I think Dr.
Bill, you're on mute. Your mic.
Yeah. Dr. Bill, we can't hear you. Still can't hear you. Okay, while he's doing that, Dr. Aluya. Dr. Aluya is double, those double-boarded physicians in pediatrics and internal medicine, the double residency that we have in there. So is also president at NAPAC. So kindly unmute and ask your question.
All right. Well, thank you so much. I'm actually one of my places where I do some work. Dr. Ajagbe, incredible work you've just done, and I appreciate the fact that you brought this on to the forefront so that people listen to some of all this and the emotional and psychological problems that stem out of it, and that a lot of parents don't talk about, especially with ADHD. I mean, as a pediatrician, there are times where I've had to talk to a lot of parents, and some of them, in fact, I had a godchild who I knew had ADHD, and I spoke to the mother like, listen, your child had ADHD. The earlier we start to put this child on a constructive measure of intervention, both psychological and chemical, meaning medications, the earlier for her, so that she can adjust properly and do well, especially when it comes to academics. Because one of the biggest concern and complaint that they have is failure to adapt and adjust to the school environment, especially with work and understanding how the system here works. So otherwise, if it continues for a long time, guess what? The child will feel, I just don't know what to do. I'm a failure. I'm not good at anything. And the first thing they tend to do is want to reject schoolwork, and then they drop out, and they drop out easily. And especially if there's no background, home support or family support or structure, as we know that we don't have in our Black and brown communities here. Now, my typical example was, it got to a point where at one time I traveled to Nigeria, the mother called me, like, come come and see your godchild. I can't handle it no more. And I said, listen, and she called me all the way while I was in Nigeria, for a trip. And I said, but I told you this, But eventually, the time we put her on a structured program, she began to do well. I also have others who gone through the same thing. This child was so hyperactive that he ran through a glass door and split his face. We started on the meds. The kid who was failing came out top overall class in the school. So these things happen, and it's frustrating, both to the parents and to the child. First and foremost, to the child, and then, of course, the parents. So I'm glad you're bringing those and relating it to other issues with sleep apnea. A whole lot of things are intertwined, and we tend not to, put one-on-one together to make two. Now, I'll go back to a few things. I'm glad where you talked about weight, obesity. It's a big issue. It wasn't a big issue where we grew up, where I graduated from, but it became a big issue here. And studies have shown that if your child is obese at age 10, that child will most likely be obese for the rest of his life, and all the attendant issues that come with it. Now, we see what obesity has done in this country. And unfortunately, it begins to creep into, back home. As people's socioeconomic status improves, they become, move from very low socioeconomic class into upper socioeconomic classes. These things begin to come, and the attendant problems that they come with. The neck size you talked about, incredible as well. With obesity comes with neck size. But I'll take it back a little bit, 2 steps backward, and I'll say this. Here in the developed world, one of the biggest achievement they've always been able to have, and we used to read about it and eventually until I came here, was how they were able to maintain, preserve, and save children who were born premature. And people don't tend to remember that a lot of kids who were born premature, they grow up, and some of them stay 2-3 months on the respirator or in the NICU, and they survive. But they grew up with problems with the brain, where the respiratory centers don't respond well to them as they grow up. That's one. 2, the intubations that they get for all that long tend to also create some problems in the airways as well. And we tend to forget that. I've had situations where some of my residents, they're like, oh, doc, this woman has COPD. And I said, COPD at what age? Oh, he's 32. Like, why would a 32-year-old have COPD? Well, he smokes. I'm like, how long has he been smoking that you get COPD at 32? No, go back and ask if the child, if he was born or her was born premature. And they come back like, yes, because our kids are surviving longer and longer. So all of these things tend to occur as well. And as pediatricians, we tend to forget to take that history properly as well. So all of those things have a way of affecting the airways and affecting them as they grow up, causing obstructive sleep apnea. Now, on the exposure to immunogenicity, like somebody had said, we know as children grow up, they tend to build, that's where they get exposed to all the immunogenic response that is in the environment. And of course, they tend to build their immune system as well. And in developing countries, guess what? We give them vaccines. In developed countries, we give vaccines. In developing countries, where do they get their vaccines? From the streets, where they play in the mud. So as they do that, all the Peyer's patches and lymph nodes and centers begin to grow. Some of the ones that grow is in the larynx and the pharynx as well. The tonsils, the adenoids, they tend to grow really big. So, and they tend to grow from age 3 up to age 10. And that in itself, if you ask those kids, open up your mouth, you see them, the adenoids are kissing. They call kissing, tonsils. And a few of them have had to, a few of them have had to have surgeries because those things tend to affect them. Now, when children are set up to have tonsillectomies, we unfortunately, I think now it's becoming a standard where post tonsillectomy surgery, they go straight to the ICU. Because across the country, about 10 to 15 years ago, there were episodes where children bleed and they go into respiratory failure and even a noxic brain injury because it was just a regular tonsillectomy. But one too much is enough for them to come up with recommendations like that. So these things happen, and we see these things happen as well. So as kids grow up, we tend to also put that into cognizance so that if you feel your child has obstructive sleep apnea, take the child to the doctor and let them have a comprehensive physical examination, history taking from birth to the time where the child is lived. And of course, as well, take a strong family history of the parents, because sometimes things tend to run in families as well. Dr. Ajagbe, you talked about the bedwetting. That's a whole story that a whole lot of people, I mean, look, there are times I used to scratch my head too, how to manage some of all this. But one of the things we also tend to forget is what they call posterior urethral valve. A lot of kids have that and they're go undiagnosed. And unless it begins to cause kidney issues where they tend to have kidney hydronephrosis, we don't recognize that. But thank God some of them over time, they just wear off and they go away. Do we go to investigate? We don't, you know? And of course, psychological issues at home, maybe issues of abuse, physical, emotional, economic, financial, even sexual abuse as well happen to those kids, and they begin to bedwet. And for children, just like in adults where, what do you call it? And I often say this, that tachycardia, meaning your fast heart rate, is the first sign of impending doom. If something bad is going to happen, the first sign that you get is your heart rate goes up, irrespective of what it is. Bedwetting is also a very, very early sign of something really bad happening to a child. So I know you talked about those studies, but my question is, I wonder who those studies were done on. Were they done on our kids, African-American children, or Black kids, or were just predominantly Caucasian children as well? You know, and a few other things. I must say thank you, and it's a pleasure being here. God bless you.
Thank you.
Thank you so much, Dr. Aluya. Oh my gosh, you guys have blown me away. I mean, I'm taking home so much. I'm going to do sleep study on all my children that I have, and I'm treating for ADHD. It's important. The bedwetting too. You know, we just give that DDAVP, you know, that nasal spray. Yeah, use that and call it a day. I'm going to make sure I investigate all of mine now, just to see the bottom, the underlying problem. But Dr. Ajagbe, Dr. Aluya asked the question about, you know, the population of those that were investigated in that research. Were they all Caucasians? Are they mixed? What race were they?
I think that there was no racial, definition. The inclusion factor was the fact that the children have sleep disordered breathing. Sleep disordered breathing, the commonest of them is snoring, different kinds of breathing issues that children have, what they use to select this population that they studied. It was not a race-based kind of study. It was just a direct correlation between sleep disordered breathing and the trajectories of neuropsychological development over a 6-year period. So I will not be able to say anything about whether race has something to do with it or not. What I can say, though, is that what we don't think about, we will not look for. For instance, if you'd never thought about sleep apnea being a potential cause for bedwetting, you're not going to look for it. You're just going to assume that, well, the parents didn't say anything about sleep apnea, so I'm not going to do anything about sleep apnea. But you have to remember that parents do not even know that their children have sleep apnea, because if they do, they'll be the first to cry wolf. Or, to take the child to the doctor and say, well, this child keeps stop breathing while sleeping. So can you do something about it? Is there anything that is wrong with my child? But most of the time, the parents don't know. The parents themselves may have sleep apnea undiagnosed. So, it could be just like that there's no way the sleep apnea will be diagnosed ahead of time. But if it is an obvious situation that the parents observed it and they can say definitely by self-report that this is occurring, then maybe the study will be done. So my thing is raising the awareness with this kind of chat or discussion, just allows physicians, just like you're saying a few seconds ago, that you're now going to be looking more into sleep issues concerning your children, the children that have been diagnosed with ADHD under your care. And that is the first step that we must all begin to take, because we want to improve the quality of life for these children. Because sleep apnea is one disease or one clinical condition that not only reduces the quality of life, it also shortens the length of life. So in every way, sleep apnea is not to be ignored at all, because the long-term consequence of that also is cardiovascular problems, which in many cases say you have patients that have uncontrollable, high blood pressure. Nothing you've done for that patient is changing. Well, you must check their, sleeping issue. You must check them for sleep apnea. If you evaluate them for sleep apnea and they turn out to be, to have sleep apnea, then if you manage it, you find out that this blood pressure will go down. There are bodies of literature to support that. So I appreciate you saying that you begin to review children who have ADHD to see if they have any issue with sleep. That will be very helpful to them.
Thank you so much, Dr. Ajagbe. Dr. Bill, can you come in now? We still can't get you.
Okay, while he's doing that, Madam Lara, Auntie Lara is on. On mute, ma.
Thank you, Dr. O. Yeah, very interesting conversation. So now that we know all of this, would you guys in the medical field start to make recommendation to pediatricians or any of those, so that for early detention, like Dr. Ajagbe rightfully said, a lot of parents, it doesn't even have anything to do with your intellectual level, may not be aware that their parents their children stop breathing at night, especially in this age of, so to speak, luxury. Everybody have a room. We grew up with 2 people in one room or 3 people sometimes. So somebody is snoring, you elbow them, stop snoring. But these days, you don't know what is going on with your child in the next room. And I think that with all the preponderance of the evidence that you have and the different organs or the subsequent debilitation that this one simple sleep apnea can cause, I think that the prevention should begin probably, I'm not sure what age you would recommend, but we should start to make a case for this so that, people are more aware. Until I started coming to Medical Monday, I wasn't aware of sleep apnea, to this extent. I wasn't. And people snoring, where I come from, Southwest Nigeria, it's not a big deal. They just kick you and say, stop snoring. We didn't know that, People don't have control about whether they snore or not. I never knew that. So now that we are being educated, what are we going to do about it? Because it shouldn't stop here. What kind of policy change needs to be enacted, so to speak?
Well, thank you for the question. That is a very insightful question. Many times it's through studies, it's through publications and presentations at different scientific gatherings that most of this information will be disseminated. It doesn't get the attention of the policymakers until, there are some fatalities in most cases. Even when AMA or ADA or all of these organized, the professional organizations are writing white papers and submitting it to CDC and all of that, until somehow, whatever the long route that their policy processes take, we don't know. But the most important thing is that we recognize it and begin to raise the awareness among the public. Once the awareness is heightened in the public, the media carries it, then the policy makers will begin to see that it's not just for the poor, Black, Latino segment of the population, but it's affecting the whole population, not just in the United States, but globally, that maybe they will begin to see it as being important. I think when money is tied to it, is very important that they will know that the spending over $9 billion on Ritalin or the medications that they are using to treat ADHD could be reduced tremendously if they only diagnose. If they diagnose the children and they know that they have obstructive sleep apnea, the amount of money they will spend treating sleep apnea will be a fraction of the $9 billion that they've been spending annually just to medicate these children that have been diagnosed with ADHD, for instance. So I'm not a policy maker, and I wish those people who are in policy making corridors of power will be able to hear the information that is being circulated and then do something about it. But yes, we could write recommendations, we could write white papers, but if the policy makers are not considering it, it will still be sitting on their desk somewhere. One of the reasons why I went, in fact, the main reasons that I went to Nigeria in December that just came back, was to take awareness, to begin to introduce the information to the public in Nigeria. By the time I got to Nigeria, I already had a radio station that wanted to, have me present, particularly because it has to do with safety on our roads in Nigeria. Sleep apnea is a big problem, and the government doesn't even know it. The lawmakers in Nigeria, they fall asleep during their sessions in their chambers. They're not aware of any danger that they are in, because many of them have sleep apnea. You see all of them overweight, big jowls and big tummy, and they go to sleep snoring and they don't even see anything wrong in it. So that was my goal, to see how far I could go with raising the awareness about sleep apnea. I was successful in many ways. The first was I was able to be on the radio 3 times, addressing the traffic FM radio station in Lagos, and Sunny Irabo show, one on a Sunday, the Sunny Irabo live show, which is multicast. and also a Zoom meeting still on Sonny Rabot show as a follow-up to the first presentation. Then the last thing I was able to do was to actually get the Nigerian Dental Association present a Zoom, had a Zoom presentation for the Nigerian Dental Association, where close to about 100 dentists participated in that, including all the deans of the colleges of dentistry in Nigeria, because it was like, where did this come from? It's like, really? This is so serious? Well, it was good. And now that the dental school, the dental group in Nigeria have begun to understand the grave consequence of not treating sleep apnea, maybe there'll be changing, adding something to the curriculum in order to look into how dental aspect of sleep apnea can be taught in dental schools. So it's all about awareness.
Do you have testimonials? Because that is one way to make justification for change in policy. If we have people that we can demonstrate and say before and after, and people can actually give a recount of what their life was to show what has changed after sleep apnea was diagnosed, and what age
yeah.
do you?
Yeah, actually, what you're saying is using, personal testimonies are always important in any kind of policy making decisions. However, unless it is, let me put it this way, if the goal is to raise awareness to the public and raising it through the media or multimedia is the first approach. This next approach will be, after treating most of the patients that are now becoming aware, submitting themselves for treatment, and then they having testimonies or testimonials, then that will be the trend to go. Remember, the same problem in Africa is what it was here in the US. The sleep apnea is not being diagnosed on a regular basis. Most of the places where you have sleep apnea being diagnosed from the Medicare, and that is the highest. And the only way you can figure that out is the amount of money being spent on Cpap in the United States of America for those people who are qualified under Medicare, and even on Medicaid in some states. And so you can see they have means of doing something about it if they really want to. It's not like they don't have information, but I guess like any other research data that is collecting dust in archives, maybe they're not even paying attention to that until it affects somebody in their family.
Yeah. Thank you so much, Dr. Ajagbe. I have a more positive outlook to this. For instance, see what is going on here. In my practice, what I heard tonight is going to make a difference. I'm going to start, in fact, I'm going to look at all of the kids who have ADHD and send them for sleep apnea study. In fact, my adults too, because it's the same. What sleep apnea is doing to adults is horrible. You've gone over that with us here. We've done that before. And that's why, thank you. I'm so glad that you decided to, focus on children today. You've made a change for me. I'm going to share with my friends, and we're going to start making a ripple. The friends that are not here tonight. Part of the reason we do Medical Mondays is to gain these facts. But what Madam VP just said is very important. It takes us. It's like, when we were, fighting to have hepatitis C recognized here, and HIV was going on. We took it on. And guess what? They recognized that on the Hill, and a difference was made. A point you made at the end, though, that when it hits the family of the people that matters, who can make changes, then they will. But it starts with us, because we have to start doing the needed testing. We have to get the word out. I never associated ADHD with obstructive sleep apnea. I never associated bedwetting with obstructive sleep apnea. You know, and so these are critical informations. They are very important, and it's going to make changes. Madam VP, stay tuned, because you know we'll get the word out, and it will get to the right ears. I'm very positive.
Dr. O, if I may say a word or two.
Please, go ahead.
It's incredible for those who get sleep apnea treatment. It's like day and night when they tell you the effect of the sleep apnea.
That's
being
the
resolved.
Cpap.
Yes, the Cpap. It's day and night. When they come back, the testimony is incredible. And people tend to forget, if sleep apnea persists for so long, the direct effect is on the lungs, and where it increases the blood pressure within the lungs. It's called pulmonary hypertension. And that is really deadly. And if it goes on for a longer time as well, that pulmonary hypertension tends to affect the heart. So you have pulmonary pressure affecting the heart, and the heart begins to fail. And heart fails, it spirals down to the kidneys, and you have 3 organs failing. Now, in addressing issue of sleep apnea, I think we always have to take things in 2 prongs, and I always say, first, look at it in children, and then looking at it in adults. Now, in children, that's the very time you start early intervention. And that intervention would include everybody. It's a multidisciplinary approach that, the good doctor said, because it starts with the mother or the parents, as a matter of fact, and including the siblings. Madam VP has said, something earlier on. Back home, they're like, this guy, you snore too much. You're waking up. Everybody cannot sleep in the house because you snore. And that's the early time most people tend to, notice that somebody has a problem with sleep. And then if you ask further, they'll tell you, he stopped breathing sometime at night. And it begins there. And such a way that the mother and the parents would also bring the problem to the doctor. Now, everybody in this stage will have to be an advocate, in the sense that, one, as you report to the doctor and your child's been diagnosed with sleep apnea, it's time to see if there's no, a group for sleep apnea children. Form one. That's how you begin. You form one, and you'll be shocked that a whole lot of parents also have the same problem. If it's bedwetting, the same information we just talked about, share those things, so that as at that point in time, we'll begin to collect one another, and families begin to talk to one another and advocate for issues that concerns their children. And listen, you can push on the agenda and get doctors to talk about this. And as doctors begin to contact, you form affiliations and associations and friends within those doctors who will take it upon themselves. Like my good doctor here now, it's an issue he's interested in. You look for people like him. He will also look for people who are like him. And then guess what? As parents, you have a power. You can begin with the local level, go talk to your councilman, push the agenda from your councilman to the mayor, from the mayor to the Congress. And guess what? You can push an agenda and go to Congress as well. If you cannot do that, look for the local, organizations. For instance, I was the president of New Jersey Medical Association in the state of New Jersey. And I represented the state of New Jersey doing what? Pushing an agenda for women, especially women of color in childbirth. Because like they said, if you are Black, irrespective of your level of education or socioeconomic status, you're 4 times likely to die from childbirth as a Black woman. So that was one of the agenda we took on because it became an issue that people pushed on. Two, we talked about diabetes in the community, even residency positions for Black people, for Black medical students. So we took that to Congress. So, and that's how the movement has to be pulled on, where parents, associations, doctors would have to come and become advocates for their children. And that's how policies are being made. And that's how things change. And I often say this, change often comes, but by the determined will of a committed few. Change often comes, but by the determined will of a committed few. It's not everybody that will create the change. It's just a few. As they come together, they begin to form that critical mass that eventually will create change. And that's how we begin to do it here. And listen, my brother, I love what you did when you went to Nigeria and talking about it. Because you see the storm that took place here in the United States, it's coming in Nigeria. And I've always said that God forbid that our generation will be the generation that see our children die in front of us because of obesity, bad food, and everything else. So please, let's stand up. Let's advocate for our children. Let's advocate for our community. Thank you.
Thank you.
Thank you. Thank you.
Let me just say one thing, Dr. O. Let me say one thing. Thank you very much, Dr. Aluya. You know, one of my goals for going to Abuja a few times was to try to get the attention of the legislators. So I put something in motion to try to address them at some point because most of them are suffering from it, but they have no idea. And, you know, and so I'm going through. I'm hoping that somebody is on. Okay. I'm expecting to know that this is possible to address them through their legislative institute. So once that is on, maybe that's one way of getting the attention of the policymakers or legislators to see that the accidents, the fatalities on our roads in Nigeria can be directly attributed to or indirectly to sleep apnea in most of those drivers. If you look at the cycle of their sleep or the cycle of their day, the way they spend their day, and many of them having long hauls from the north to the south and back to the north again. Many of them have been put under pressure in order for them to deliver. All of these things are part of the things that I was trying to raise awareness about when I went to Nigeria, this time around, just to let people know that we can improve, safety on our roads, if people are sleeping better. If they sleep well at night, they will be alert during the day. They will not be as irritable and easily offended on the roads. All the congestions are not because the roads are bad primarily, but because many people are sleepless at night and they get on the road in the morning and they are all irate. They are all angry with one another. They are honking. I mean, if you never knew there was a horn in a car, go to Nigeria. Everywhere, every second, there's a honk. So these are some of the things. And if the underlying causes are not treated, one of which is sleep apnea, we will just be spending money on the irrelevant stuff and not getting the result that we need.
Thank you so much. There's a question from Yomi Ogun. Says, kindly highlight treatment measures. Is Cpap usable in children?
Yes, I'm sure sleep apnea, Cpap is available to different ages. It has to be titrated though by the technician to get the right amount of pressure to keep the airway open. You cannot buy it on eBay and say you want to save money and then you want to buy a low-grade Cpap online. You need to have a prescription for it, and you need to get it from reputable manufacturer who can back up the maintenance as well as calibration and titration of the machine. If a child has severe sleep apnea, Cpap is the first that it must be used. If an adult has severe sleep apnea, Cpap is still the first line of action until they, another kind of adjunct treatment can be added to improve it better and more, or to replace the Cpap. Cpap is still the first line, which is non-invasive, but it is very inconvenient to many people because of its. Some people feel claustrophobic. They can't use it. They are very uncomfortable when they use it at night. Those are the reasons why non-compliance is very high in those people who are using Cpap, whether children or adults. But like I said earlier, there are at least 37 treatment modalities available in order for, to manage sleep apnea. And I already alluded to the one that actually goes to the underlying cause, and that is to grow the jaws that are underdeveloped, to open the nostrils that are blocked. And all of these things can be done with a device that we call the biomimetic appliance.
Thank you so much. Let's see if we can get Dr. Bill this time.
Thank you. Yes, thank you.
Can you hear me?
Yes. Yes.
Hallelujah. Hallelujah. Thank you for your advice, Dr. O. My questions I've been trying to ask, basically, Dr. Ajagbe and Dr. Luya, you've hinted at it. One of the things, of course, is nutrition. Some cases that I've seen in terms of children, they have come to me, and they have they are allergenic due to something which has caused their adenoids, their tonsils, to always be basically inflamed. And the parents keep feeding the child the same thing that's causing the problem, thinking that it's something else at this point. So it's based on educating parents about the importance of what they're feeding the child, and also doing an assessment in terms of things which might create a subclinical allergenic response, which is not being diagnosed at that point.
Okay, that was what I was trying to clarify. That when you say subclinical, I was assuming that you mean before it is diagnosed. So yes, let's take it from the developmental standpoint. Most of the children that you said have allergies, yes, they may have allergies to environmental allergens. They may have allergies to food allergens. They may have it to chemicals that are being used in the house, air freshener or disinfectant or whatever it is, even soap, even the shampoo. There's so many, possible sources of allergies or allergens to every one of us, not just children. And you're right to say that the diet is very important. The diet is as important as the environmental condition. So all of these things can contribute to the worsening of the sleep apnea. Now, the pathophysiology is simple. When we're talking about the enlargement of the tonsils and all the lymphatic organs that surrounds the airway, we're not talking about, food directly. We're talking about environmental allergens that actually are passing through the mouth and the nostrils that are escaping the nitric oxide that is supposed to disinfect. So the sterilization of air through the nostrils is very, very important. And where the problem starts, and if you gloss over it, you will miss it.
Mm-hmm.
Upper respiratory restriction syndrome is a situation where the nostrils are blocked, whether they are partially blocked or completely blocked. Once there is upper respiratory restriction, the default is that the mouth opens. It's like a way to stay alive, because air is not going through the nose. And if air is not going through the nose, the 5 things that the nostril does will not happen. If the air goes through the mouth, it will not be filtered. There is nothing to filter the air going through the mouth. There is nothing to, well, you can say saliva will humidify, but it's very inefficient when it comes to humidification of air. Mm-hmm. When you talk about the nostrils, you need the nostrils to not just increase the humidity, filtering it, but you need it to warm the air. The air going into the lungs have to attain certain temperature to be able to go into the lungs without irritating the lungs. If you step out into the cold air and you do not have the ability to warm your air that goes through your nose and it goes straight to your lungs, you start coughing. The air going through the nose must be warm to the body temperature in order for it to go into the lungs and be useful without irritating the lungs. The next thing the nostril does is the air will be accelerated, because the air by itself cannot just come in and flow to the lungs. The air must be accelerated through the ways the nostrils, the nasal cavity is formed anatomically in order for the air to flow through what we call the turbinates. In order for the air to flow in an aerodynamic way to go directed into the lungs, through the larynx. The next thing is the air must be disinfected or sterilized with the nitric oxide that is being released from the sinuses. The maxillary sinuses, the sphenoidal sinus, and the ethmoidal sinuses are releasing nitric oxide, which disinfects or actually sterilizes the air that goes into the lungs. Now, when that is not working, that is, the nostrils are blocked, the mouth has to open. And all those things that the nose is doing are not going to happen, because the air is going directly past. The only gateway to disinfect the air are the tonsils and the adenoids. And that is what they do best. They have to capture all the infective agents, whether it is viral, whether it is fungal, whether it is bacteria. They will gather all those things and then try to contain, and that is what is causing the enlargement. And that's what we call lymphadenitis. Lymphadenitis means they just get inflamed and they get larger. Any inflammation will cause release of fluid. The release of fluid, hyperemia, that is increased blood flow to the area. There will be release of chemicals like prostaglandin that will cause even more leakage of fluid into the tissue. And these are the reasons why you have the enlargement of the tonsils as well as the adenoids. Those are the gateway to the air that is going through the mouth into the lungs. Unfortunately, the tonsils and the adenoids are not as efficient as the nitric oxide that is coming from the maxillary sinus. So there is no replacement. If you don't breathe through your nose, then you will not be healthy. There is no way, there is no second way about it. You cannot dodge it. If you are not breathing through your nose, you will not be healthy. When you breathe through your mouth, your breathing will be loud. That's number one. There is no way you can breathe gently through your mouth. Number two, you will have dryness of your throat. Continuously, you have sore throat. When you have sore throat, the lymphatics that drain the throat are the adenoids and the tonsils. So it's still the vicious cycle. So you have sore throat, you have the adenoids enlarged, the air is like Dr. Aluya said, you have what we call the kissing tonsils, because they are so big that they are actually touching themselves in the midline.
Yes, understood.
During the day, the air will not flow easily. For somebody whose nostrils are already blocked, whether it is from food allergy or environmental allergy that their nostrils are blocked, the tonsils are already closing the airway in the back. So how are they going to survive? The brain is not getting enough oxygen. The lungs are not healthy. They have asthma because all of these irritants are going into their lungs and they will have bronchospasms. So wheezing is going to be part of their lifestyle. They must be breathing heavily and wheezing loudly. You can hear them across the room. So all of these things are as a result of this structural defect. What we call the hypoplasia, mid-facial hypoplasia, is where the nose is. Once you have mid-facial hypoplasia, is a structural problem. If there is no way of, if you don't manage that, there is no other way to help somebody that has sleep apnea.
Have you measured nitric oxide ever?
Have I measured it?
Yeah, level of nitric oxide. You know, there are things out there which allow us to measure it now in terms of the body's ability to perform in the proper way.
Well, I mean, I haven't done it personally and I've not requested for it. However, it doesn't mean that they're not available. It's just that the awareness is just being directed in the area of sleep apnea right now, knowing that upper respiratory restriction will make sleep apnea worse. So if it makes it worse, measuring this nitric oxide, even if it is high, let's say it is high, but the nostrils are blocked, the sinuses are inflamed. Even if you have the normal level of nitric oxide, what is it going to do to the air going to the lungs? Nothing. So the upper respiratory restriction syndrome is something that must be addressed, very critical. I mean, very aggressively. Once you can manage that, and one of the best way to manage that is to grow the jaw so that the nasal cavity can actually be expanded. Because most people that have mid-facial hypoplasia, their nostrils are small. And more importantly, the nasal septum, the division between the right and the left nostrils may be deviated one side and causing it to be closed completely. And those are things that must be managed or treated first before there will be improvement.
If I may say something a little bit quickly on the nitric oxide. Nitric oxide is an amazing chemical that's produced by us as human beings. And there's a whole lot of study that's been done on it. It's something new. But the unfortunate thing, I say this, we as Black people, we don't produce that much nitric oxide. We really don't. But coming to the chemical of nitric oxide, it has very short lifespan or short, life, and it's quick, and it's produced by certain chemical processes. I don't want to go into details of it, but it's produced predominantly from one of the very essential amino acid, glutaric acid, and you can get it from a certain amount of food. And that's why, as Black people, we need to identify those foods and eat them. Now, in terms of management of asthma, it's something that's still new. They begin to measure the amount of nitric oxide that's produced in the airways. There's a little contraption they use now. It'll give you an idea of the severity of asthma. As we know, there's mild, moderate, and persistent asthma, or mild, mild, moderate, intermittent, and persistent asthma. So you can actually use it as a measure of the severity of asthma and how much you need to intervene in terms of that. So, but again, just like Dr. Ajagbe said, the longer your sleep apnea persists, the longer it damages the productive ability of the airway to produce nitric oxide that's beneficial to you.
Thank you so much. Oh my gosh, thank you. So just so everybody's question can be answered, I'm going to call on the first person, Sister Tower, then Dr. Maureen, and then Sister Rosemary. In that order, as you raise your hand. Sister Tower.
Good evening, everybody. Thank you very much, Dr. Ajagbe. I mean, it's like you are looking at me and you are saying, though mine is not actually obstructive sleep apnea. I had some procedure done last week and my tonsils, my adenoid is all swollen. I can still eat. And actually I left here to talk to my doctor because he called me back. Is it going to go back from that swelling? Because I know it's inflammation. I am feeling terribly, terribly, terribly bad for almost 11 days now. So when the adenoid and the tonsils are swollen, are they going to go back on their own? Then two, who is the doctor that, because antibiotics doesn't work. It's not an infection, it's inflammation. And who is the doctor that sent you for sleep apnea or anything like that? Which of the doctors? Is it your primary or is there a specialty doctor that you have to see?
Well, thank you very much for the question. When we talk about enlargement of the tonsils and adenoids, unless it is allergic, in etiology, that is, if the cause is allergy, then antibiotics will not be able to do anything about it. But if it is as a result of infection, definitely antibiotics will be able to do it, whether it is, if it is bacterial infection. If it is viral infection, I don't know that it's going to be prolonged enlargement. However, the body will still be, the reason the tonsils and adenoids get enlarged is because the body wants to get rid of whatever it is that is causing the injury. The injury is within and the body is trying to get rid of it. And one of the ways by which the body gets rid of it is by inflammation. And the reason it's enlarged and red is because the body opens up the small vessels and let more blood come into that area, sending the white cells that are supposed to attack whatever is causing the problem to mop them off. And while they are doing that, the body also releases, there will be chemicals released, that causes the destruction of the tissue themselves, which is why many times when there's bacterial infection, you have pus formation. Pus formation is not, directly from the bacteria themselves, but because of the chemicals that are released as a result of being, the white cells killing the bacteria will cause the destruction of the surrounding soft tissue. And that's why we get all of this. Now, if antibiotics is not working, it might be two options. One is maybe that maybe the antibiotics is not the correct one, so they can do culture and sensitivity if it is bacterial infection. If they do culture and sensitivity and they find out which antibiotics is most effective, once they use that, the infection will go down. But if it is due to if the inflammation is due to allergy, well, allergy has to be treated, either with steroids or whatever your primary care physician or ENT surgeon, if you are referred to a specialist, can prescribe to take the swelling down. The other potential reason for having that swelling not going down is if it is a neoplastic. That is, if it's a tumor. If it's a tumor, then they have to do a biopsy. They have to check it out and find out what kind of tumor it is, and then decide, whether to take it out or to use chemotherapy or any other thing that you need to do if it's a kind of tumor. So I think the first thing is whoever did your procedure should be the one to follow you up on that. They should, at least, no matter what specialty that is, they should be able to tell you what the situation is.
Thank you, sir. Sister Tower, the short of this is that what Dr. Ajagbe has nicely outlined is that the reason for the swelling needs to be identified and then properly taken care of. And the ENT who did your procedure will be able to do that. But to refer for sleep study, it's your primary care doctor who will refer you for sleep study. ENT can do it too. Basically, let me say this, it depends on your insurance. If you have HMO, then you need your primary care doctor to refer you. If you have, I'm sorry, somebody is causing me to echo, so I'm trying to find out who. If you don't have HMO, then you can go to any specialist you want, then you can just do that. So check your insurance, and we can chat off forum, okay? So discuss more on how you can get those testings. So Dr. Maureen.
Hello?
Thank you. Hello.
Can you hear me?
Yes.
Yes.
Yes. Thank you. This was so educational for me as an anesthesiologist because, sleep apnea is something that we work with. People for non-ENT surgery, for anything, can have sleep apnea. And over the years, I've seen a lot of work done, even our assessment with the stop bang method. Two things I wanted to say. If people like their sleep, if they use the sleep apnea mask, they love it. I had a patient once, the first thing he said to me in recovery room, "Give me my girlfriend." I said, "What do you mean?" He said, "That instrument. I sleep with her every night. That's the best thing that ever happened to me." I always think about that. So I encourage people to use it. And also, using it prior to surgery helps to reduce the edema from snoring. Secondly, I'm really glad to hear of other modalities because UPP that we used to do before doesn't seem to be working much anymore. Within the last couple of years of my practice, I didn't see a lot of UPPs. Also, when it comes to children, I was listening, we now have adult premature kids, and they have moved from pediatric anesthesiologists to adults, and that immaturity of the young is a big deal now because a lot of us never had these premature kids who are now adults. And the airway, apart from other things, the airway was not well developed. So they tend to have these asthma-like things, but it's just the poor development of the lungs. And the other thing I wanted to mention, I think I got more. Oh, I have done a lot of kissing tonsils. And we did not send kids to the ICU. Tonsillectomy has become in and out, but they're kept long. I think it was 6 hours. And we do have bleeding post-op, but it's not very common. But the only thing is that we say to them, it gets worse before it gets better, because what you have there with the tonsil, it gets bigger because of the inflammation from the surgery and all the swelling. So it takes a while before you get it. And the other thing you could tell kids after adenoids, they just don't sing properly. It's very hard for them to sing. They don't phonate properly. So that was one of the problems one of the kids I know had. And that's about it. But thank you, Dr. Ajagbe. This has been a very, very interesting.
Thank you. Thank you, Dr.
I was trying to leave, but I just couldn't. You got me tonight.
Thank you.
Thank you so much. Thank you, sis. Sister Rosemary, my darling sis, I'm asking you to unmute. Kindly unmute. Okay, so I'm going to go to my sister Monique, and we'll come back to you. Great.
Hi, thank you so much.
Hello.
I wanted to know, first of all, Dr. Ajagbe, I'm sorry for the pronunciation. Are you local in the DMV area?
Yes.
Yes.
Oh, okay. Maybe I need to check him out. Secondly, I wake up tired every single morning, every day of my life. And my cousin was staying with me at one point, and she said, "Are you okay?" She said, "I thought you were gonna die last night." I said, "What is going on? What happened?" She said, "You're choking in your sleep. Do you not know that?" And I don't know. So I do know that I cannot sleep on my back because I feel like I can't breathe. And then some nights I jump up out the bed and gasp for air, feeling like I'm having an anxiety attack. So I wanted to know, what would you advise me to do?
Classic.
Okay. Well, first of all, we're not establishing any patient-doctor relationship by discussion, so that you're not going to say, well, you said this, you said that.
No.
Okay. So, yes, the fact that you wake up tired every morning of your life shows that you're not getting enough sleep. You're not getting enough sleep because you're not getting, you're stopping to breathe at a rhythmic rate. That is, maybe it's about 10 times an hour that you stop breathing, and then you start breathing again each time. And that's what we call sleep apnea. That's what it's all about. When you fall asleep, your tongue relaxes. The soft palate of the roof of your mouth in the back also relaxes because it has muscle. So what happens is when you fall asleep and they relax, they fall to the back and partially or completely block the airway. So that's why you say you can never sleep on your back, and that's absolutely true. If you slept on your back, that's exactly what's going to happen. And when it happens like that, and you are not awake, your brain will sense that oxygen level is at about 80%. When it's at 80%, the brain now starts to arouse you to wake to a state of awakefulness, but you are not alert. You are not really awake. But you kind of just at a level that you can move your jaws in order to open the airway so you can breathe again. So your brain is telling you, you've stopped breathing. I want you to start breathing. The only thing you must do now is be awake enough to be able to move your jaw. Wow. So when you move your jaw forward, your tongue your tongue moves with your lower jaw, and then the airway opens, then you continue breathing. And then when you fall back asleep again, everything goes again in the same cycle. So the muscles relax, boom, they close the airway, and that's why.
Wow.
Because you are not sleeping, okay, say it like this. If your relative or your friend or that stayed with you woke you up every 10 minutes and tell you, oh, go back to sleep, Monique. And then another 10 minutes wakes you up and say, oh, don't worry, go back to sleep, Monique. And does that a few times per hour, multiply that by the number of hours you stay in bed. So
Wow.
if you stop breathing 30 times per hour, and then you slept for 8 hours in the night, you have stopped breathing 240 times. And when you stop breathing for at least 240 times, you stop breathing for a minimum of 10 seconds to 60 seconds. The maximum anybody will stay alive when they stop breathing is 3 minutes.
Oh my
You know, that is, they will still be conscious.
Yes.
If they slip into 4 minutes, they fall into the boundary of having been brain dead, because oxygen level to the brain cut off for up to 4 minutes means the brain will not revive. So that is like a permanent vegetative state. They cannot be conscious again. The brain is dead. The organs may be functioning, but the brain will be dead at that point. So you cannot afford not to breathe for an extended period of time. So when you wake up every morning, is because you have stopped breathing several times and your brain has not gotten enough oxygen to cleanse it through the night. You have not slept deep enough to be able to rejuvenate your whole system by the time you wake up in the morning. The only time that we feel refreshed in the morning is when we actually slept deeply.
Yes.
If you are constantly at a very lucid level of sleep, you will not feel refreshed in the morning. It doesn't matter how long you stayed in bed. There are people who say they stayed in bed for 12 hours, but they still wake up tired. They still wake up groggy. They still wake up not totally confused. So for you, what I will say is definitely you have to do a sleep study.
Okay.
The sleep studies are many. I mean, there are two main types of sleep study. One is the one that you go into the lab to do it. Okay, you go into the lab, they will hook you up, you know, you sleep there overnight and the technician will monitor you. They do, some places they will do a video recording of all your movements and all of that, the brain wave and your chest rising while you're breathing, how many times you stop breathing while you're sleeping. It will cut, you know, it will do all of that for you and they will give you a report. Usually the summary of the report will say you have either a mild, moderate, or severe sleep apnea. If you do have sleep apnea, that means you do stop breathing while you're sleeping several times per hour before you, while you're sleeping. So if you, the second type of sleep study is the one that you do at home. I have the one that you can do at home. It's simply a ring that you wear on your thumb or any of your finger, and then it will do exactly what the lab is doing at a fraction of the cost. So yeah, so that is available right now. It's not like maybe it's a pipe dream, you know, it's already available and it's very accurate. It is FDA approved for sleep study in children and adults. So it is something that, you know, I just took it to Africa to try to raise awareness about that, to let people know that there's help. There's need for treatment, but you can't treat without diagnosis. And the simpler or the easier the diagnosis, the better for everybody. So that's why I don't make, advertisements, in presentations, but that might be helpful to you in case you need to have a sleep study done.
Okay, I'll get your information from Dr. O.
Sure.
Thank you so very much.
You're very welcome.
Thank you.
I did that sleep study test. See, I was blessed. I was the guinea pig. I was used as guinea pig to try it out. It was so simple, just put it on my finger and went to sleep. And if you get up in the middle of the night to use the bathroom, it doesn't affect it. When you lay that down, it continues automatically and does what it needs to do. And it's transmitted into some computer and the report is generated. Really
I
cool.
want one tomorrow.
Really cool. Don't worry, I got you. So, Sister Rosemary, great.
Okay, good evening, Dr. Dr. Ajagbe, everyone. Thank you very much for the information. And my story is that, I had sleep insomnia for a very long time. So I went for sleep study. And the day I went for the sleep study, they put all kinds of gadgets on my body, on my head, and I didn't even sleep that night. So how can they diagnose me that I have sleep apnea? And then they gave me the machine. I'm using it. It still has not even solved the problem of insomnia. And, the machine is very good. The day I sleep, I really sleep. I sleep very, very well. But I still open my mouth, wake up with dry mouth. So which means I'm still snoring through my mouth. So how can I?
Okay. Well, I'm sorry I'm chuckling because it's just like any other thing. If you have bacterial infection and somebody said that you have malaria and they are giving you malaria medicine, you will not improve. So it's the same thing. Diagnosis is very important. Now, if you already knew, somebody already diagnosed that you had insomnia, well, they need to manage insomnia first. And then if you then stop breathing while you are sleeping well, after the problem of insomnia is solved, then that problem of sleep apnea can be addressed. They could be comorbid states. That is, both of them could exist together. However, if you don't sleep for real, you cannot be diagnosed with having sleep apnea because, what events are they monitoring if you didn't sleep? If you didn't fall asleep.
So they gave me the machine. I refused to use. I'm like, the problem is still there, and you give me the machine, and they charge me. I pay $100 and something every month for that machine.
Well,
I don't even use it.
Well, so you will have the option of saying you don't want it because it's your body and it's your decision. The worst is that they will ask you to sign a release that it's you that is giving up the machine. But if it is not helpful to you and is not addressing your underlying cause, then maybe you need to see your physician again and have your sleep situation and re-evaluated. The key is if you fall asleep for less than 4 hours, most of the studies will be, you will have insufficient data for evaluation in most cases. So that is very interesting that you didn't fall asleep and you still had a reading for sleep apnea.
Do you know what I have been doing recently? I have been monitoring how I breathe in the daytime, and then in the nighttime, I'm able to sleep and wake up very refreshed. I tape my mouth before going to sleep at night, a little bit.
I am very impressed with what you have done. There is a way. This is very interesting.
I've trained myself. So even if I don't sleep very well, the next day I can function very well because I take my mouth, I don't open my mouth. I'm training my nose I'm training myself so that I can be able to breathe through my nose. And I've been doing it.
I am so impressed. What you have done for yourself.
I am beyond impressed.
This is intuition. Do you know that there is a treatment called Boutaikov breathing system?
Breathing, I do it. I do Boutaikov breathing.
Yeah, Boutaikov,
that's exactly. Yes,
that's what you are doing. because the key is to be able to train your nose to breathe.
Yes.
You do not want to breathe through your mouth. You must. Well, okay, if you do Boutaikov breathing technique,
yes,
then you can always keep your nostrils open.
Yes, it's open now. I don't have
okay,
to
so
totally
you know what you need to be doing every time your nose is blocked is you must create air hunger for yourself by holding your nose.
By holding my breath, yes.
By holding your breath until you feel like you can't hold it any longer, and then you slowly breathe through your nose, not through your mouth. You will not breathe through your mouth.
Yes.
And when you do that 5 times, your nostrils will be open.
Yes.
And then when it's open, if it goes back again, then you do it again. By the time you do it 3 or 4 cycles, your nose will stay open. And you don't need any medication. You don't need any nasal drop or nasal spray or anything like that.
That's right. I'm doing very, very well. You know.
Wow. I am so impressed. Oh my God.
I feel very, very good. My sleep, everything is fine now. Yes.
Yes, that is. You see now, if everybody is listening, what I was saying about upper respiratory restriction syndrome is what she has just managed.
Oh my God.
She has just managed it by herself.
Yes, you're right, Dr. Ajagbe. Thank you very much.
I wish you all the best.
Thank you, doctor. Thank you. God bless.
Keep taping the mouth. So,
I tape it, and it's working very well for me.
You have to. You have to.
Thank you, sir.
You're welcome.
Thank you so much, sir.
There's a question in the chat. Madam Lara wants to know if sleep apnea has any correlation with insomnia.
No, they could coexist, but one doesn't lead to the other. They could coexist. That is, somebody who doesn't fall asleep and stay asleep naturally could have sleep apnea whenever they eventually fall asleep. So if they coexist, so somebody who during the night cannot fall asleep, but early in the morning, while everybody is about to rise up, they fall asleep, and then they have sleep apnea. They need to be diagnosed for both. The treatments are not the same, particularly if it is anatomically based. If there is upper respiratory restriction, like we just talked about a few minutes ago, that has to be addressed first to open up the nostrils so that the individual can breathe through the nose and not through the mouth. If the patient breathes through the mouth, they will have issues with their tonsils and adenoids and with their lungs. And once that is going on, they may not be able to sleep at night, not because they don't want to sleep, but because they can't lay flat, because they have asthmatic type symptoms. And all of these things coming together will make sleeping very difficult for them.
Thank you so much. Another question from Dr. Manasseh Abija. Thanks for the awesome information you have shared. Very educative. Now, why do adolescents have a delay in their sleep-wake cycles? Is this good or a necessary evil waiting to cause to wreak health havoc?
I'm not sure I understand what delayed sleep cycle means. Does that mean that they don't go to bed early?
They don't go to bed early.
And they don't rise up early. They don't want to wake up early when adolescents are adjusting to a lot of things. I'm not sure what the age of the adolescent might be, but any adolescent that is going through hormonal changes and all the different changes in the body will affect part of the way the brain functions as well. And I think Dr. O and Dr. Aluya, as pediatrician, will address that probably more comprehensively than I would. But I think it's also a habit. Nowadays that everybody seems to be addicted to some kind of electronic device, the blue light from the device, will affect the part of the brain that actually releases the melatonin that causes us to stay asleep or fall asleep easily and stay asleep longer. All of these things are going on with the adolescent, and unless there's self-control or some kind of control, that will continue. It's a habit that must be broken.
Mm.
Thank you so much. And one comment from Monique Williams. She says, awesome information. I'm feeling guilty for never knowing to get my son tested for sleep apnea. He had severe asthma, was a chronic bedwetter, diagnosed with Adhd, and had behavioral issues throughout his school years. Thank God we survived. We tested for everything except sleeping habits. Amazing, no one ever advised us to check. Thank you so much. He is 32 now, but I will advise him to get tested.
Yes, I will say yes to that. He still needs to be evaluated for sleep apnea. The fact that he survived the childhood abuse from sleep, not a physical abuse from anybody, but the abuse from sleep is that he wasn't getting enough. The brain was battered by low oxygen concentration for extended period of time. That made it, you can imagine what could have happened if he was getting enough sleep. If he survived now through all of those rigor of not sleeping well and being labeled as having ADHD and not having good concentration in school, maybe not doing as well as he should, all of those things could have been like the opposite. He would have just been excellent in every way if the brain was able to develop and get the amount of oxygen consistently that it needs to develop.
Wow.
Wow, what wonderful conversation we have in here. Great chat. Dr. Opeyemi says, thank you so much, Prof. Ajagbe, for the highly informative session. And that leads us to our Medical Monday moment.
Whoa! Whew. Excellent conversation. Oh my gosh. I am so excited. I learn every week. And I get so excited. I cannot contain it. Thank you so much, Dr. Ajagbe. Thank you, Dr. Aluya. And thank you, Dr. Maureen. Oh my gosh. It's like you guys came, planned to do the tag Dr. Ajagbe team. We really appreciate you. On behalf of everybody on the forum, we say thank you. Yes, Medical Mondays moment. We're grateful to be here. Can you believe today is the last day of January? It's like we started January a few days ago, but the month is gone and we are here, healthy. And I just want to praise God for that. Today, we are going to give a precious sister of ours, of mine, the Medical Mondays, gift. She's a woman who, oh my gosh, behind the scenes does a lot to just make sure that everybody is well, is right. And that is what we need in our community. That is what we need in our society. Somebody who is there regardless of race, where you come from, where you don't come from. No. That's what Medical Mondays is about. That's what this woman is about. And that's why Monique Williams today will be the recipient of a sphygmomanometer, which is the machine we use to check blood pressure.
Oh my God.
So we will be sending you the sphig. We call it sphig for short, for sphygmomanometer. And I want to just say thank you.
You're going to make me cry. Thank you so much.
For all you do in every area, every arena. Thank you for your support of everybody that comes your way.
Oh my God. Thank you so much. It's nothing to me, but thank you so much. I'm going to cry. Wow.
Thank you.
Thank you so much.
You're welcome. Thank you.
Thank you.
So we'll now revert back to Dr. Ajagbe to give us his concluding statements. What would you leave us with? Oh my gosh, you've been awesome.
Well, I mean, thank you for everyone that has been very involved in and engaged, during this conversation. I'm glad that the awareness is increasing gradually. It's just starting because even here in the US, the concept of multidisciplinary approach to treating sleep apnea is in its infancy. It's just starting. And incidentally, it seems to be starting from where most people didn't expect it. It's the dental group that has been pushing it, primarily in California, in Colorado, in Canada. And so the movement is starting and is gaining momentum. I was in Las Vegas last year before the end of the year. And that was the reason why I went to Las Vegas. It was one of the biggest conventions of multidisciplinary, physicians and craniofacial, sleep dentists, everybody coming together to pour over the literature and see how we can all tie these things together and see how an internal medicine specialist cannot say, well, I don't need, a dentist in the management of this person, only to find out they're going to fail, and then they will have to come back to the group that they said they're not going to be able to work with in the first place. So I know that Dr. O has made a proactive statement that, I will be checking with her just to encourage her that she's remembering to do exactly what she says she will do. Because if those children can be taken off of medication and they are treated for sleep apnea and they are way better than what the side effects of medicine will give them, I'll be so glad that I've done something to improve the quality of life of at least one person. So I believe that is where all the physicians need to be. Dr. Aluya already alluded to the fact that, we have to do the advocacy part. Yes, Madam Lara raised that issue first, but all I need to know is this. The awareness must start with the physicians themselves. If the physicians are turning their nose up, I'm an ENT, I don't want anybody touching anybody who has sleep apnea, I'm the only one who's qualified to do this. Well, many of the patients that they have are not getting better. So if their blood pressure is not improving and anything is not changing, well, maybe they need to begin to look at multidisciplinary approach. I didn't say that dental has all the answers, but at least there's a device that is available out there that can actually help a 3-year-old all the way to 93-year-old. That is the oldest person that is using the device as of this moment. So all I can say is that there is hope. There is answer to the question. The question is, should sleep apnea be killing everybody silently? The answer is no, because there is a solution for that problem. And the solution comes in 37 different ways. And that is, you don't have to be stuck with one thing. If one is not working, there are many others that may be able to work for you. Thank you very much for the opportunity to share tonight.
Thank you so much, Dr. Ajagbe. Immense gratitude to you, Dr. O, and all, Dr. Aluya, and all those who contributed and commented on tonight's discussion. We are so grateful for all the questions in the chat box. Tonight, we discuss obstructive sleep apnea in children with a doctor of dental surgery, Dr. Oluwole Ajagbe. It's been an interesting discussion, eye-opener, and I hope you will continue on your end. Awareness is key, advocacy is key. Let's bring this to the forefront. Remember to catch up on previous episodes of Medical Monday with Dr. O on the YouTube channel. A lot of interesting topics have been discussed, and don't forget to share the links to your family members and everyone you know. We are grateful that you join us, but importantly, remember our mantra: strong health, strong future. Until we come your way same time next week with another interesting discussion. On behalf of Medical Monday, Dr. O, my name is Christopher J. Thank you for joining us, and good night.
Thank you. God bless you.
Bye-bye.